Okay, first thing to say is thank you for the invitation to come and speak today. Seen a lot of familiar faces in the crowd already, so you might recognise a slide or two within this presentation. I've been given a challenge in itself to come up with the content of this presentation, which was to identify the challenging issues within point-of-care testing. Well, you know, there are many, as we all know, and we're hit with them every single day, trying to deliver a service, a quality service. And basically, it's our job to identify issues and to correct them, but also to put a quality system in place in the first place, so that we can press forward and not really be on the end of the phone every single day dealing with issues that could have been avoided. So I think I've tried to stick to a few key things. I'm not going to have enough time to go into a lot of detail in some of these, and I hope I don't do a disservice to some of these issues. Some of these issues would be a half-an-hour presentation on their own, but just to identify, here's some key things that we've identified, within our service when we were putting together our initial team and getting a ratified sort of policy together. We suffer from the same problems that you guys suffer from. We have limited resources to deliver, a very wide scope of point-of-care tests and to keep the quality as high as possible. So without running down through the list, because we'll go on to each individually, I'll skip forward. Efficient use of resources. How do we do that? Well, basically what we've got is, people asking, how big is your team? We've been around as a point-of-care team for a number of years, and we grew out of chemistry special investigations within our own department, because that was where blood gases was being looked after, urinalysis, glucoses. It was all very chemistry sort of based. Then the scope started to get a bit wider. There was hematology involved, co-oximetry, those sorts of things. Then INRs, ketones, all sorts. So we started looking into creating a team. So our team actually grew out of an established team that was funded. So we haven't had to go through, some of the pains that other people have gone through of trying to put business cases together to actually get a team. And all of our costing model for tests has a little bit on top for staffing. So, we didn't have to go out and procure or get further funding to actually put extra staffing into our team. It has grown over time, and that's basically down to the risk of some of the issues in point of care, and that we did need central funds for resources, but there's never been sort of those business cases put together that people ask me for sort of advice on how we did it. So we've never actually had to go through that. So, but the other question is asked quite regularly is what constitutes a team. Now, we've got a different approach, I think, to many, in that we don't just look at the people who are assigned the point-of-care roles within the laboratory to go out there and deliver this service. We look beyond that, and we look at a network sort of approach to governing our point-of-care and working quite closely, which we'll come on to. We've got 4.5 full-time equivalent staff in that team of different grades, 7 for the point-of-care coordinator down through half a band 6, and then we've got some associate practitioners and ATOs. We have pretty much 6,000 staff working just in the trust, and that's not even in the community. So, our scope goes beyond the walls of the trust itself, and we do get out in the community quite often. So it's very difficult to actually balance what we need to do in terms of quality and governance with the number of hands that we've got on the deck. So what we look to do is look where point-of-care testing is actually being used, and then we try and identify who those stakeholders are, who's got the vested interest in delivering a quality service at the front line. We define who's got the responsibility, and then we get people to take ownership. Now, anybody who's done some leadership training and heard like first follower, champions, those sorts of things, we look for those people who are going to push forward on the agenda that we've set through the point-of-care policy. And you've got to have that integrated team approach to delivering point-of-care, or else it all falls apart. And you've got to have a governance structure around it to actually enforce the policy itself. So we don't have anybody working in isolation, and there's certainly no one person who's got overall authority. It's all done by committee. So this is our approach. We don't really look at the point-of-care team and the users as being different. We try and engage as much as possible with the users, new information being shared, going out onto wards and actually being the face of the pathology side of point-of-care testing. We involve all the stakeholders in decisions, i.e. writing tenders, scoring tenders, those sorts of things, making changes to quality policies. And we communicate regularly through a number of ways, which I'll come on to later on in the talk. We just get everybody actively involved, really, in delivering that agenda. So who else is involved? And I've tried to highlight a few people here. It's a long list, but we've got medical device link practitioners and cascade trainers. We need to spread that burden of training. Blood transfusion nursing team, they're out there, going into the same places that we go into as the point-of-care team. You often see them walking out of the same ward or theatre or outpatient area at the same time as you're walking in. Well, they could be doing audits, they could be doing training. So we've tried to add that joined-up thinking. And then we've got people who are very invested in point-of-care, in paediatrics, nursing specialists, for instance, critical care team. There's not a day that goes by in the week that somebody's not calling us or they're coming up to our office within pathology and asking for support or feeding back to us on the performance within their own part of the service. Okay. And those are the people who have the potential to actually deliver on the agenda that you set out in your point-of-care policy. So in terms of trying to be efficient, working efficiently, now, I didn't come up with this. This is a couple of our associate practitioners said, we keep on going into different areas of the drive to open up this folder and that folder. So they just came up with an access database, which was hyperlinks to all the different areas that we need to access on a daily basis. So you've got middleware there on the left. You've got some EQA websites that you can go to. You've got Oracle Learning Management. That's our training and development web package. Training databases, our main database, which will hold all of our policies, procedures, quick guides, cost data, that sort of stuff, and a bit more EQA down the right-hand side. And we've got one there called Somerset Urinalysis EQA, because we actually provide EQA support to areas outside of our catchment. So that's not us producing EQA solutions and sending them out. That's us redistributing. But we will do all the performance and all the compliance statistics and feed that back to those organisations. And at the bottom, you've got a couple of graphs, tables there, which basically give us a heads up on when our return dates are for our EQA. So it's all very visible on a dashboard. So we don't miss any return dates, or we get to chase up some of our point of care people engaging in EQA for returning our own samples. Training and competency, massive burden for everybody. The competency side of things is something that we're working currently to put something fit for purpose in place ahead of a UCAS visit in January for point of care. Talk a bit about that a bit later. But we generally do face-to-face training, back that up with e-learning. We have a competency document that needs to be signed off. But what we're learning now is there's got to be some sort of objective review of that person's ability to do the test. So there's got to be a statement there from the trainer who themselves has to be competent to deliver the training. So where does it stop? If that's delivered by the supplier, we're now going back to the supplier to say, can we have the competency document of your trainer to show that they are up to the standard you expect to deliver the training for that test? So where does it stop at the end of the day? We need to incorporate updates. We sometimes get letters, or we get alert notices from the suppliers. Sometimes that doesn't go beyond pathology, which is wrong. When we make changes in the background, we've learned from those errors before. People don't then change their practice out there at the coalface. So it's all about that information cascading all the way down to the user. And again, spreading the workload with the training. We used to go out and do face-to-face training as a point-of-care team. And then we started using e-learning and self-recertification within the middleware. You've got to have that further input with the competency side of things as well, observing people actually doing the testing and signing them off. So we've learned by that as well. You can't just rely on your middleware to be certificating people after a year or 2 years. There's got to be this objective review as well. So a little bit on governance. Won't dwell on this too much, but basically, to have a compliant point of care service to 22870, you're going to have a policy that's ratified by the organisation. That's usually a medical director or above. Also, a quality manual for your service, which sets out, what the expectation is within the service for quality, how you're going to deliver that, how you came to make your mind up on what that quality was going to be. That's another thing we've learned from our medical laboratory assessment recently, is that you can state what you're doing, but you have to evidence why you're doing it that way. I think CPA was a slightly different take on that, which was, yeah, they're doing what they say they do, but there was, we've never really evidenced why we do things the way that we do, and I'll come on to that with a bit of quality assurance. You've got to set up a multidisciplinary committee or group. So again, doing the taking action, making decisions by committee, having a number of people from all walks and all backgrounds, scientific, nursing, training, pharmacy, procurement. They've all got to be involved in delivering this agenda, and try and build up that network as well. So again, you've got a policy. Is it enforced? Yes, you've got a governance structure. Do people understand it? Do they read it? Probably not the whole document, but as long as that information's feeding back and good practice is being shared, then you should be in a good place. Now, this is kind of a loose structure I've just put together, showcasing some of those teams on the right-hand side and more of the governance structure on the left. So the point of care team's obviously in the middle of all this. We have some local point of care team meetings on a monthly basis, or if there's an issue comes up, we drag everybody within the lab, clinical, managerial leads together with the team. But the way that we deal with new services, for instance, or ongoing quality issues, that's through the governance group. And if something is beyond us taking action or appropriate action, then it will go up to the trust governance, safety and quality teams. We get really good engagement all the way across the trust, which I think is refreshing. You speak to a lot of people who say, I just can't get buy-in from a manager. Nobody's taking point of care seriously. The scope is quite narrow. You've got people coming to you asking for new services, and there's no mechanism to actually take that forward. This is how you do it. You set up this structure, and you keep to it, and you don't deviate. And even for us, our procurement team, if they see any orders going through the system for anything point of care related, it then kicks directly back to us so that we have full oversight of people who are trying to buy new test strips or a piece of equipment. And by going out and doing auditing and things, and looking at those sites, we do still discover those pieces of equipment that pop up or have been in a drawer for 5 years and somebody's dusted it off, or a clinician's gone away to a presentation or a networking day and come back, we want to bring this new piece of equipment in, and already set up a meeting with the supplier, and you're sort of on the back foot then thinking, well, do we go ahead with this? We haven't done an appraisal of anything else that's on the market, so we need to be careful there. So another thing that we're just going through a medical laboratory UCAS assessment at the moment. We've got one section to do within our blood sciences, and we've got about 10 of the ologies under one roof. So immunology still to do, so all the chemistry, hematology, coag, blood bank, molecular, it's all been done. One of the things that was picked up in terms of quality, and we're going to learn from this ready for our January assessment, because we've got point of care assessment looming, but a couple of months to prepare and learn from our current experience. So IQC, yes, you're doing it, but is the appropriate frequency being put in place, and is that related to the stability of the test? That's one of the things that we haven't done in automated chemistry, for instance. We just do 3 times a day, multiple levels of a QC, but who's to say that's right for every analyte? Are you wasting lots of QC? Are you over quality assessing that assay? So it's those sorts of things that UCAS seem to be looking for. EQA, again, is it fit for purpose? Number of participants in your group. If you're in a group of 1, 2, 3, then really are you getting that benchmarking? You're not really getting that value from being in that EQA scheme. Frequency, number of samples within that distribution. Does it cover the analytical range often enough? All those sorts of things need to be taken into consideration before you choose either a QC program or an EQA scheme. Control documentation, not just that it's version controlled, but it's up to date, it's reviewed regularly. We're looking at annual now, whereas previously if you looked in QPulse, you would have seen that some of our documentation was being reviewed every 4 years, for instance, completely nonsensical because things can change quite rapidly in pathology and also in point of care. That your information is accessible to all, so put that onto your trust intranet, your website, and having an awareness of national guideline changes, and this is going to inform your workload because we do work with pharmacy quite closely on their issuing of stock, And where you've got things connected to middleware, you can look at workload as well, which really comes in handy. But once you start seeing those spikes, it's understanding whether what's driving those spikes. Is it wastage? Is it poor performance or poor techniques that are leading to that? Or is it literally that the indication is a national guideline is driving that? So in order to deliver your point of care service, you've got to have a good engagement. And luckily, we've been through all of the heartache to get where we are now. So I've broken it down here. The implementers, so we're heavily reliant on our IT. And unfortunately, we've got IT that's centralized. We've got then a clinical systems team. We've got the pathology IT team. Bringing all that together, now we've got a person in the centralized IM&T team who is a point of care project lead, who understands point of care where they never did before. They didn't know where, what your drive was, understanding the middleware, what it could deliver for you in terms of governance and quality. And then you've got the vision, obviously the point of care coordinator, horizon scanning, myself offering support as the point of care manager, and also the clinical leads. We've had wonderful engagement from our clinical teams over many years, even though those personnel have changed. Really, really sold on the value of point of care being delivered as part of supporting that pathology agenda. And that's gone all the way up through the organisation. So we have service lines within care groups, and also, we took a big paper to try and get as much connectivity as possible to the digital care records group. And they basically just signed it off. We did a 10, 15-minute presentation. They said, absolutely see the value. And they backed us all the way. So hopefully you have similar experiences with your own trusts. And then we've got the regulation, so the governance group, and we've also got medical devices strategy groups, of which we have a standing agenda on. So performance monitoring, another challenge. How good's your service? What's going wrong in the service? What is performance? What we tend to do is a monthly report that goes to the governance group, which is very detailed. We also do a CG report, a clinical governance report that goes back to the pathology lab on a monthly basis. And it's really the highlights and lowlights of what's happening that month. And at the bottom, you've got annual management review, and that's where you can collate all your information very simply from all your clinical governance reports into one annual management review without digging through at the last minute, to try and find the information that your medical lab requires. We do a periodic review, which was very much based on the CPA 3-monthly periodic review that we previously have put in place, but that informs your audit calendar. So you're finding issues within your service. UCAS won't want to see recurrent audits doing the same thing every single month, getting the same outcome, and everything's okay, another tick box exercise. You do your audits, find an issue, and then you put a corrective action in place and put something else on your audit calendar to go back and see that it's effective. You don't want to be doing the same thing over and over again, because there's no value in that and you're wasting your resources. Metrics data, again, all about performance and KPIs. If you've got contracts with your suppliers, are they meeting their obligation? You need data for that. I'm going to come on to that with a few indicators here. I don't think I've got a pointer, but top left is point of care training, so we monitor that. Down here, here we go. Excellent. Yay. Okay, we're monitoring workload going up. These two in the middle I'll talk about in just a second. We've got staffing levels, so we have a breakdown. It's just good for our own sort of understanding of where people are deployed and what type of leave they're taking. And we've got error rates, so we can look at how many times we've been called to certain areas for certain tests. It's not all about blood gases. This will be done for each of the tests within our service. But if you look at these two middle ones, this is EQA return rates. The bottom line on both of these is pre-chasing up. And if we didn't have the team, we wouldn't have that top line. And you set your compliance rate at whatever it is. I think, I'm not sure if NEQAS is the same. WEQAS, I think, says 80% for point of care EQA. We try and keep to 90%, so we're slightly below, have been up around 90 previously. And then urinalysis is not quite so many of those, so a bit easier to keep it slightly higher. But you can see the difference between these two lines. And if we didn't have an effective point of care team going out there with additional samples or phoning people or turning up with ward managers, we wouldn't have this data and we wouldn't keep the compliance rates high. Now, that doesn't necessarily mean that their performance is good. It just means they're participating. Now, taking it a step further, some of you may have seen this from other presentations I've done. This is what we want to be working with. This is a dashboard in the future which is going to capture everything from incidents in the top left-hand corner there. So you can see where quality is being captured and reported back, or issues being reported back. Non-conforming work reports within QPOS, our quality management system. How many audits you're doing, training figures, are they going up? Does that support more resources, or trying to bring other trainers from across the trust in? Analyzer uptime, downtime, workload statistics. There's lots of data on there, and we want to be a couple of clicks away from a report for a period of time where you can then do a comparison with previous months and see which direction you're going in. And we're kind of coming up with this league table where people have been the worst offenders or improving. You want to see that. And also temperature monitoring, a big thing that's come into our laboratory, let alone point of care, over recent years. Just having a hyperlink to find out that data very quickly. Accreditation, just quickly touch on. Not sure how many people are actually going for accreditation, but we certainly are in January. And back in 2012, we got CPA accreditation. We just bundled everything together and said, right, connected, non-connected devices is all going in. We'll see what comes out, trust and community. And basically, we were awarded CPA. Now, UCAS is a different beast altogether because, like I said before, I think CPA wanted to see the structure in place, that you were doing what you were saying you were doing, but not how you arrived there. Now, come January, we're hoping to be ready. We've only put in connected devices at present because we're sort of dipping our toe in, but most of our scope is connected thanks to a pan-pathology tender that's just gone through recently, where we changed glucoses and ketones and urinalysis. We've also got blood gases and a number of different middleware that connects up INRs and HemaQs and the rest. So there's very little that's outside the scope that's been incorporated. And as I say, medical laboratories going through now, we've been pulled up on our use of validation and verification. Validation, we're told, is for things like where you make up the reagents in-house, maybe for LCMS and HPLC and things like that. You have to validate that test. It's not CE marked. Anything that's produced by a supplier, you're just verifying that it's meeting the performance of those suppliers, what they state in the kits. So yeah, we've learned from that. So every single validation report that has validation in every other line has to be changed. So yeah, just bear that in mind. Just thought I'd put that one in there. Value and effectiveness. We already talked a little bit about the effective nature of keeping your EQA up, but there's different ways of getting value into your service. I would say through your initial procurement, that's where you're looking for your value. You don't want to be wasting your resources on procuring the wrong instrument or the wrong test. What you should be looking out for is low repeats within that service, little downtime of analyzers, the least amount of maintenance possible, full oversight through connectivity, and also very important to establish a baseline before you make that change. So then you can actually go back and say, actually, we've procured the correct solution here because it's effective. We're not running around as much as we used to. We're not responding to so many breakdowns. We haven't got problems with training and competency. People understand how to use this kit. It's moved on. It's the next generation. And also your business partner. They're not just there to provide you with tests and pieces of equipment and then say thank you very much and we'll have an annual review with you to just see how things have gone. I'm expecting our suppliers to be on site, to go out and talk to the users, to put on a few events here and there, and get the trainers in, the people who are actually straight there with the users, delivering the agenda, and understanding where we go. Got to contribute to the vision and understand actually what your vision is and where you're heading and what journey you're on and what part they play in that journey. And that's the way you get added value. And I don't think we're being cheeky at, asking for that. And even if you're not going through a tender where you can write specific things of added value in there, don't be afraid to ask, with your current contracts that are in place. Very quickly touch on communication. Try to do this in life as well as in service. Listen, act, learn, review. And then you listen, act, learn, review again. And that's all to do with staff, users of the service, the trust itself, and the business partner all working together to deliver that agenda. Now, we know a number of different tools that we use for this. There's a newsletter that goes out, and one of our suppliers helped out with making this look professional. This particular one, you may not be able to read the small writing there, but it was all about clinical governance. It was all about the user's role in that, the service, how people report issues, who should engage in the process, and what their input was into developing new policy. We've got a GP leaflet, which I've got a screen grab of in a moment, daily emails that we can piggyback for key information. So if we identify something on day one, we'll be putting that out to all users on day two, and we'll be going out and doing face-to-face, sessions with people to make sure they're aware of problems. There's a weekly trust e-bulletin that goes out, again, training dates go into that. We've got a dedicated inbox that people know they can get a response from. It's always open, it's always manned. And again, e-learning, that's where we get a lot of our information out. And this was a GP leaflet that I actually stole from Gateshead. So thanks to Gateshead, put Plymouth Hospitals on it, and just changed a few of the things on the back page, which is the right-hand side. Just asking GPs, are you doing any of these tests? Well, if you are, you're doing point of care. And this is how we can help you. So on the right-hand side is all about what structure we've got in place, what support we can give them, and that can be on a number of different levels. It can be, controlled documentation. We'll write it, we'll put it in place, quick guides. We can come out and do the training, or you can come into the trust. It's just making sure that people in the community are aware of what's available, because I don't think they are currently. And if everybody's trying to do things in isolation, you're going to get things done 20, 30, 50 different ways. So it's trying to pull that together into one way forward. Now, I've got probably 5 minutes to just quickly run through, 2 minutes to run through. So, real-life problems, okay? I'm going to skip down to the problems because people like to hear about real-life solutions, I think. Go on to very recent, GFR being released from a blood gas analyzer when the creatinine was suppressed due to QC being out. Software glitch, obviously that GFR has become available to the wider healthcare community, and this was in ED. So 31 patients were affected there. Try to do a screen grab to show where a value is there against the GFR. Completely nonsensical if the creatinine result, which is suppressed, still goes into a calculation in the background and gives you a GFR. That just isn't right. So we're working with the supplier to get on top of that. Again, blood gas. We found very recently, calibration's fine. QC's within limits, running 3 times a day, I think the QC's run. Linearity looking good for the assays on board, but sodium, left-hand column, if you can see that, very low sodiums, which you would take action on. And the lab results on the right-hand side, we saw a mean negative 13 millimoles per litre. And it's without having people out there in areas with point-of-care testing, identifying these issues and saying, we think there's a bit of a problem with our blood gas machine. QC's not reflecting that. You've got to go a bit deeper, and we had to do this comparison in a very short period of time. So it just shows you how fragile things can be, and you have to be reactive. We adopted a GEM 5000, first global site, early 2016, verified the system, put it into use, full installation, but then we started to see the severely acidotic patients. We couldn't get any PCO2s, and we couldn't get pHs out of the machine. It was all incalculable. We looked back through, did a data trawl with the supplier, and we found 11 sets of results out of 11,000 had this phenomena around it, and that wasn't picked up in the supplier's own sort of testing before they went out into market, and it was CE marked and everything else. So we've worked with the supplier. They've been very rapid in their resolution. They've changed the software and the algorithms to allow a pH now to be reported as less than 6.8 if it is so, instead of just saying incalculable. And our clinicians were happy that at least they knew down to that level that, it wasn't 6.9 and incalculable. So, and the PCO2 results are now released satisfactorily, and we've started a second rollout of that piece of equipment. And the last one, we identified a lot strip issue quite recently on urine pregnancy testing, and we took the lot back, just rushing through this one really, took the lot back. We couldn't put it down to storage conditions because the lab was seeing it, we knew it was good storage conditions. The same lot number was underperforming out on the wards as well. We had our consensus EQA for that lot number, so again, worked with the supplier. They put put their hands up. We haven't had any reports of this lot being a problem elsewhere, but we'll take that lot off you and replace it with another lot number which we verified was working to the level we expected. So just a couple of wrapping up messages. Coming to an effective and rapid resolution is dependent on engagement from clinical management and scientific leads and will lead to minimal impact on patient care, as I've just shown with some of our resolutions there. But make sure you record those resolutions in Datix, whatever your quality management system is, and where appropriate. Just don't be afraid to put things on the risk register and manage actions against that risk within your organisation's risk register, and you can't really go far wrong. So don't think in terms of point-of-care teams. You can talk about teams if you're talking about the wider point-of-care establishment. Think about point-of-care network, and that's where you can pool resources and an integrated approach to delivering that point-of-care service. Okay, that's enough from me, I think.
Thank you very much, Cindy.
Thank
you. Just a couple of minutes for questions before we break. I've got one for you. On your quality dashboard, do you think there's room for a pre- and post-analytical monitoring element, which there wasn't there at the present time? Yeah,
I think so. Actually, with one of our blood gas providers, they're looking at establishing hemolysis on samples. That's one of the biggest pre-analytical sort of errors that you can't detect in whole blood at present on any system that I'm aware of. So that work's ongoing. We do a lot in the laboratory, which it's more difficult then to get out into the point-of-care community. But getting the right sample from the right patient and doing the right test at the right time is obviously key.
And would it be helpful for you to monitor your local performance against other networks through things like PrepQ?
I would think so. At the moment, the benchmarking is not quite there. You've got quality assurance, which shows how people are performing particular tests, but not about the performance of an overall service, I don't think. So, if that can give us any valid kind of information, then I'd be all for it.
I think we have time for a couple of questions from the floor. Gentlemen.
Yeah. Are you talking about critical being outside of technical ranges and having to act on? Yeah. Most of the middleware is configurable, but your hospital network isn't to such a degree, and you might get some up and down arrows or a red arrow next to a result. But in terms of the interpretation of that, we're very reliant on the training and the supporting information that we give about reacting within a protocol. Yeah, I would say that they do support that through it depends on how configurable that middleware is. And I think there are different levels, especially with our laboratory middleware at the moment, which we could piggyback with point-of-care testing. There are different alert ranges that are definable by the user, which can be carried forward into the hospital. We haven't done that to the degree I think you're describing, although there is a constant review of IQC and QA data that informs whether or not that particular assays are performing well. But it's understanding how that interpretation is taken out in where the service is provided and whether that's taken on board. I don't think we've got full view of that at the moment.
Thank you. Okay. So we just have time for one quick question response because I don't want to keep you from your coffee or tea.
I wanted to ask, so I saw that you had a newsletter that went out to the GPs and you were kind of advertising your services.
Yes.
Was that a paid service or were there different levels, and what kind of response did you get from that?
Initially, we were starting off with just wiping our own faces, I guess. So we were getting the income back in just to pay for, say, if it was the QA program, they pay for the QA program. We weren't actually costing up our time or our effort or the support. we started talking about sort of like a platinum, gold, silver, bronze sort of level of cover that we could sell out into the community or engage with the CCGs in terms of them procuring our services for that, just to try and centralise things, not as a income generator, but certainly for those areas outside of our catchment. So we're currently working with Somerset, we're currently working with Dorset for EQA. Those do generate some income, and it's based on how much resource we have to put into it and any materials that we have to put in. But yeah, usually the mention of money means that quality gets left behind and people don't adopt those services. So I think getting in early in the way that we try to and just covering our own sort of costs was the way to then sort of build moving forward. And then, you can come up with a structure that fits, for the CCG and for ourselves as a trust. We certainly can't do things at zero cost because you can't reinvest in the quality of your service, and you can't improve things for the rest of your service that you're trying to provide. That's the way we try and take money into the team. It doesn't get lost into a big pathology or wider trust pot. There is significant reinvestment.
Thank you. I think funding is a perennial problem for all sorts of services. I see there are further questions, but I have no time to do it here. So do network, talk to Tony and Tim. Apologise for not having any time for questions for Tim during the break. So we'll be restarting at 11. Couple of quick announcements. Thanks to our sponsors who've supported this inaugural meeting. That's Sterilab Services, Roche, Hariba and Oxford Biosystems. We've got a great session 2, which is focusing on accreditation, how to get it. Many great speakers, including Sarah Glover and Delia Geary, who's so often at our meetings that we ought to give her an honorary membership. Thank you for coming again. And just an announcement that Darryl Collinbridge, sadly, as a result of illnesses, was not able to attend, but thankfully MHRA have provided Moji Ajanea, who is going to substitute, so we're very pleased about that. So enjoy your tea and coffee, do talk, network, and we will see you back here at 11 sharp.